Hi, my name is Dorian Davis, and I chose to do my PowerPoint presentation on MRSA because I am a respiratory therapist and I'm constantly gowning up in PPE, and I just want to become more informative on what the infection really is and what it really does to the body and how it is resistant. What is MRSA? Staphylococcus aureus is a strain of bacterium that lives on the skin and in the nose of healthy people. Typically, it's harmless, may cause infection. If the bacteria enters the body through a break in the skin, infections are usually treated with antibiotics, and it can cause serious infection. What is MRSA? MRSA stands for methicillin-resistant Staphylococcus aureus. MRSA is a type of staph bacteria that has become resistant to methicillin and several antibiotics traditionally used against S. aureus. They range from minor to life-threatening. They live on the surface for several days. Characteristics of S. aureus: gram-positive. It's gram-positive, non-motile. The shape is spherical clumps. MRSA is a type of staph bacteria that has become resistant to methicillin and several antibiotics traditionally used against S. aureus. Its golden color, purple on stain, hemolytic on blood agar, produce coagulase and catalase enzymes. What it looks like, the purple and the golden color sheet. Here is the history. In 1941 was the introduction of penicillin into treatment of infectious diseases. 1944, S. aureus penicillin resistant. 1960, new penalase resistant drug use to fight staph, example methicillin. 1975, methicillin resistant strains of S. aureus merged. 1988, 2.4% S. aureus and methicillin resistant. 1989, 3% Enterococcus vancomycin resistant VRE. 1991, 29% S. aureus methicillin resistant. 1993, 7.9%. 1996, S. aureus strain intermediate vancomycin resistant. 1998, a man in New York dies from S. aureus. In 2000, community acquired MRSA emerged. U.S. reported 300 cases. Here you'll see the cell structure of Staphylococcus aureus. You'll see the immunoglobulins, that little green area up top. You see the protein A, microcapsule, cell wall, plasma membrane, the adhesions, the invasin coagulase, staphylokinase, leukocidin, and at the top there to the left are the toxins. Genetics: Staphylococcus resistant to oxalin, methicillin. Occurs when the isolate produce an altered penicillin binding protein PB2A, which is encoded by the MECA gene. Variant penicillin binding protein binds B lactams, which lower avidity, which result in resistance to the class of antibiotic antigens. The next slide here, it shows the genetics on what's really going on. You see the normal PB2 and to the right, the altered PB2A. Next, we'll get into the evolution. On the next slides, A, B, C, and D represents endogenous resistant mechanisms of Staphylococcus aureus. You see the evolution of antimicrobial resistant and gram-positive cocci. S. aureus, you see it was introduced to the penicillin in 1960s, which then it became penicillin-resistant S. aureus. In 1980s, methicillin was introduced and it became the methicillin S. aureus MRSA vancomycin. 1990s, there you see the vancomycin-resistant Enterococcus VRE. And then in 1997, 1997, vancomycin glycopeptide intermediate resistant S. aureus. And then in 2002, vancomycin resistant aureus. The next slide here just shows on the cellular level on how, what takes place with the resistant. This slide here represents the scheme of the decreased outer membrane permeability caused drug resistant of S. aureus. There it shows the outer membrane permeability. It shows distribution of selective membrane permeability, degradation of structure and function of the cell. You see the cell wall, blockage of protein synthesis, inhibition of metabolic compound synthesis, transcription blockage, inhibition of folate synthesis. And there you see on the squiggly part there, the blockage of replication. More on what's going on within the cell. You see this slide here represents the role of the active influx system in MRSA resistant. You see the medication going in through the influx pump and everything that's going on inside the cell there. Continue. This slide shows the role of cellular enzymes in drug resistant of S. aureus. The next slide here you see worldwide prevalence, the resistant of Staphylococcus aureus of oxacillin MRSA, and the percentages. The U.S. CDC Active Bacterial Core Surveillance Report, MRSA. The Active Bacterial Core Surveillance Report isolates of MRSA from a sterile site in the surveillance areas in 2002 through 2005. Cases are classified into one of 3 epidemiological classification cases. 5 MRSA surveillance areas. The categories are in hospital settings, hospital onset stay, the first of 4th day, the healthcare associates community onset outpatient before 4th day, and 1 to 3 day stay after. History of hospitalization, surgery, dialysis, or long care facility living residence for 1 year. Central vascular catheter within 2 days prior to MRSA culture. This slide here just shows more of the ABC results. This graph to the left is the race report. The graph to the right is the report case on chronic dialysis, peritoneal, and hemodialysis. More of the ABC report. This graph here demonstrate incidence of invasive MRSA by epidemiological class and age group. It represents the national estimates and adjusted rates on invasive MRSA infections. How does methicillin resistant develop? What does MRSA target? What does MRSA target? Infections of the skin or other soft tissue by hard to treat MRSA methicillin resistant Staphylococcus aureus bacteria appear permanently compromise the lymphatic system, which is crucial to the immune system function. Here on this slide shows target areas, the highest being in the nose. The orange area is the medium areas you see under the arm, the hand, the groin, and the low area represents the psoriasis. Here's the chain of infection. The chain of infection, the agent is MRSA. How is it transmitted? Contact with contaminated individuals, environment, or objects. Susceptible hosts, a patient with reduced defenses, individuals with weakened immune systems. To the right, you see the break in the chain. You break the chain, you break the infection. Eliminate the agent. How do you do that? You treat with antibiotics. Break transmission with 100% compliance with hand hygiene and contact precaution. Susceptible hosts are promote optimal nutrition and hydration and prevent skin breakdown. What is methicillin Staphylococcus aureus, MRSA, commonly known as the superbug, a subset of bacterial staph infection of the skin, Staph is the common name of the bacteria named Staphylococcus aureus, grape-like grouping, resistant to antibiotic, methicillin, and other antibiotics such as amoxicillin, oxacillin, and penicillin. Antibiotics do not work on the infection, which makes it so difficult to treat. Here you see the picture of MRSA. You see it infects the soft tissue, the redness around it. It's very painful. What are symptoms of MRSA? Symptoms vary depending on where the infection is located. Infected area on skin, it's swollen, red, painful, pus-filled, warm to touch, and with fever. Bacteria burrow deeper in the body, potentially life-threatening. Infection in the bones, joints, surgical wounds, bloodstream, heart valves, and lungs. Pneumonia, shortness of breath, fever, and chills. Here are two slides. The one to the left, you see the red area with the pus. To the right, that looks like maybe necrosis has set in. Maybe it's down to the bone at that point. How is MRSA diagnosed? A sample of the bacteria is obtained from the site of the infection and placed on a dish or culture. The bacteria grows and can be identified by looking at it under a microscope. The sample could be pus from skin infection, sputum from a lung infection, blood for bacteremia, bone biopsy for osteomyelitis. Treatment. Antibiotics aren't always necessary. If you have a small skin boil due to MRSA, your doctor may just make an incision and drain it. Take your prescribed antibiotics, even if you feel better. Follow your doctor's instructions precisely. If you don't take all your medications, some of the bacteria may survive, requiring retreatment. Inadequate treatment can cause development of antibiotic resistance. Prognosis. The outlook depends on the severity of the infection and overall health of the individual. It is important to start treatment early. Follow your doctor's instructions on wound care and ways to avoid transmitting the bacteria. If there's recurring skin infections, you can be tested and treated for MRSA colonization, which should stop the infection. Take the antibiotic as long as they're prescribed.